about to do an inferior glide mobilisation for the shoulder to help improve abduction. So first of all, looking at the arthrokinematics of the shoulder, so we firstly understand why we're doing what we're doing. If someone's having difficulty with abduction, obviously there's a number of reasons why that can happen, soft tissue reasons and joint reasons. If it's a joint reason, one of the things that will be happening here is as they try to bring their arm up into abduction, they're not adequately inferiorly gliding the humeral head. So what we've got, obviously a ball and socket joint with the shoulder. When we go into abduction, it's not simply rolling up into that position. We also get that downward slip of the humeral head in the glenoid fossa. And if we don't get that, then what we get then is jamming of that superior part of the humeral head up against the acromion, and we get loss of range of motion. There's a lot of factors that play into why that can happen, but if we want to improve that abduction, one of the first things we need to do is try to get that inferior glide to happen so we can restore that arthrokinematic function. So the idea is when they're doing the abduction, we're going to be trying to apply a force downward on the humeral head in unison with that movement. Now it makes sense to do mobilisation in conjunction with the movement because that's the most functional way to apply a treatment technique to get a functional outcome. We can do it passively, where their arm is in a stable position and we just glide it. Nothing wrong with that at all. But if you apply it with movement, then it translates better to function. So that's what we're going to show now. So we've got our patient here. We're going to get him to move into abduction with this arm. At the same time, I use the webbing of my other hand onto the humeral head. So not on the acromion, slip just lateral off of the acromion over the deltoid onto the humeral head. And I'm going to apply that inferior gliding force across the humeral head as he comes up into abduction. So he'll actively do the movement. I'm going to support and apply a little bit of overpressure with my other hand, at the same time gliding that humeral head inferiorly. So we're going to do that. So he lifts up into abduction, I push down, encourage that inferior glide, which is appropriate arthrokinematic function, supporting with the other hand and coming back down. Now if you're a smaller therapist and you've got a much bigger client, it's a little bit easier if we use mobilisation belts. So another option would be to use one of these belts. You can still do it with them seated on the table. The idea with this is you take the belt, you wrap it around your hips, and you sit into the belt like a harness, like you're in an abseiling harness. That belt then goes over the shoulder. Take the buckle, move it away from them and away from you so it's not across any joints. Position that belt in the same position that you would have put that hand, so just distal or just lateral to the acromion. And then I sit down onto the belt, which tensions it. So as he lifts that arm up into abduction, I sit into the belt, add some load to that belt, traction that humeral head down, and then unload it. With the other hand, I'm just applying a little bit of pressure on the back of his shoulder. Because I'm sitting into the belt, you'll have a tendency to pull him backwards just a little bit, so I'm applying counterforce across the scapula to stabilise. So it comes up to abduction, I'm guiding that arm, sitting down into the belt, inferior glide on the humeral head to encourage that movement, and then slowly release that pressure as the arm comes back down. So that's another way to use mobilisation with movement using a belt versus using your own hands.